hacían 2 miotomías de Heller, que es la técnica clásica para resolver la miotomía. Y actualmente mínimo están haciendo dos POMs mensuales desde el 2010. Sí, la casuística aumentó bastante. Eso hace que lleve más de 100 casos resueltos por él. Y por lo mismo están realizando 2 cursos por año en 2011. Tuve la oportunidad de tomar el curso en febrero de 2012 allá con ellos. Y en varios países de Europa, Sudamérica, Australia, próximamente en un par de semanas va a ir para allá a hacer el mismo curso, y obviamente muchos más centros en Estados Unidos. Esto ha llevado a que su casuística se eleve solamente a estos escasos 100, más de 100 casos, o 2 por mes, porque como hace mucho curso, pues no puede estar atendiendo a todos los pacientes, pero su experiencia es muy alta, ¿no? Ha sido revisor del comité de Notes. Notes, para los que no están enterados, es una tendencia que hubo y que existe todavía para cirugía por orificios naturales. Lo comenta los cirujanos, ya esto de Notes, pues las colecistectomías y lo que se hacía vía transvaginal o vía oral ha quedado en desuso, pero básicamente esto es lo que está quedando como Notes. Y sí se ha visto que tiene muy, muy alta aceptación. La diferencia es sobre una miotomía de Heller, es que no queda con reflujo, entonces no es necesario hacer una funduplicatura, y la casuística que muestran tanto Inoue en Japón con más de 700 casos, o doctor chino que es muy difícil pronunciar su nombre, pero lleva más de 2,000 casos, y más los 1,000 casos que llevan en Estados Unidos, pues muestran que no es importante. Entonces, bueno, pues la relevancia de tener aquí, como dijo el doctor Miranda, el doctor Marx es bastante. Nos estaba comentando, ellos tienen es director del programa de cirugía y del programa de endoscopía en la Case Western University en Cleveland, y tienen un programa de 900 residentes, ¿no? Y él tiene que evaluar a más de 100 residentes que aplican para cirugía y para endoscopía. Ha publicado más de 50 artículos respecto a esto y ha participado en libros sobre lo mismo. No quiero dejar de mencionar a quienes hicieron posible esto, que es Hospital CIMA, al Colegio de Cirujanos de Sonora. Muchas gracias, doctor Prado, por el apoyo. De hecho, también el doctor Prado, de su mutuo propio, apoyó con parte del equipamiento para este procedimiento. Y 2 casas comerciales, Smith Medical Products en Estados Unidos, y perdón, pero no salió la gráfica, la empresa D-Medica, que Alfonso está aquí representándonos, que nos apoya también con parte del insumo, que es los clips endoscópicos, que son de Boston Scientific, y que tengo entendido que está por aquí la representante. Sí, muchas gracias. Y bueno, pasamos, Dr. Marks, please. Si la conferencia es en inglés, va a ir, si alguien tiene alguna pregunta, hay mucha gráfica, igual, ya sea que no sé si quieren que estemos haciendo la traducción simultánea, o si alguien tiene una pregunta, levanta la mano y lo pregunta y hacemos esto. Si alguien lo está entendiendo, pues sí lo podemos hacer, pero es muy, muy esquemático el procedimiento. Please. Entonces, pues recibamos el Dr. Marks. La computadora. No, this is not. Okay.
This is a PowerPoint.
Pero no está apuntando.
This button to move forward and this button to rewind.
All right, thank you.
You're welcome.
Okay. Buenos días. Primero, lo siento que no hablo español muy bien. Entonces, esta lectura hablo inglés slowly, okay. Pero si pregunta, raise hand, okay? Right. Primero, I want to thank, Ernesto and your leaders of your hospital for really thinking forward and taking the next step to helping patients that are here. And there is really a great ideal in what they're doing today. Achalasia is a very rare disease, but patients that have this disease are very limited in what they can do. They can't go out to restaurants, they can't eat very well, they lose weight, and just by helping them, you may find a real change in someone's life. First off, though, I want to explain that what we're going to talk about today with POEM is not new. It may be new for this hospital today, but it is something that has been around for a good 8 or 10 years, and we have been doing it in Cleveland just for about 5 years now. So let's see, is that going to advance? That's okay, I'll just advance it here. Achalasia is a disease, as I said, that is quite rare, but there are medical, endoscopic, and surgical techniques which all can be used to manage this disease. But both surgeons and gastroenterologists and medical doctors all need to understand how to take care of this. And in this day and age, many times we can do, let's see, is this going to work? Yeah, that's not going to work. That's okay. A flexible endoscopy to help manage this disease. So, reflux disease or gastroesophageal reflux disease is very different from achalasia in terms of the causes for the disease, but the symptoms are very similar. So many times you may have a patient that you feel has reflux disease, but you may eventually find out that they have achalasia. Reflux disease has only been diagnosed for about 100 years, and it is, at least in the United States, it's the most prevalent GI disease, with about 100 million people in the United States taking medicines for reflux disease. And that's about almost 20 million people daily taking something like a proton pump inhibitor or an H2 receptor blocker. Many of these people will require chronic therapy, and that's for reflux disease. Now, the symptoms of reflux disease also may present with the same symptoms of achalasia, and that being dysphagia or difficulty with swallowing. And that's the primary symptom that people with achalasia will feel, basically related to that obstruction of outflow that occurs with that increased pressure at the lower esophageal sphincter. But things such as pain, chest pain, and heartburn also can be in both of these diseases. Reflux disease, and again, we're going to get to achalasia shortly, but reflux disease can be both a typical or atypical type of presentation, and those patients can be more challenging to identify. So what can we say about achalasia? First off, this disease was diagnosed many years ago, all right? 400 years ago, this was identified, all right, by Sir Thomas Willis in the 17th century, and he treated a patient that was starving by taking a whalebone and putting a sponge on it and putting it down and literally tearing the muscles of the lower esophageal sphincter to cure that patient. In terms of reflux disease, that is the most common disease with esophageal issues, and achalasia is the second most common. Compared to reflux disease, which we saw was about 20 million Americans daily, achalasia is less than 2 per 100,000. So in the United States, every year, about 5,000 Heller myotomies were being performed for achalasia versus 1 million gallbladder surgeries. So it's far less. Achalasia is a very rare disease. In terms of why people get achalasia, it's not known. In South America and maybe southern Mexico, you have Chagas disease, all right? We also have Chagas disease in the United States, we believe, because Trypanosome cruzi, which is the parasite which leads to Chagas, is very much commonly identified in the United States. But what happens in achalasia is that you get this hypertrophy of the lower esophageal sphincter. Is that showing up there? No, my arrow's not working there. Okay. That's fine. And then you get a loss of myenteric plexus, or these absence of these neural ganglia, which prevent the lower esophageal sphincter from relaxing. Now, who gets achalasia? It can be any of us. It is a very broad disease in the sense that it equals genders, both men and women, but also very young people and very old people. The youngest POEM patient I have operated on is 17, and the oldest is 96. All right? So it is a very strange disease that crosses all of these generations. So let's go back to some of the presentations for achalasia. Obviously, dysphagia, or the difficulty swallowing. Some people come in with weight loss, chest pain, and spitting up. They go to a restaurant and they have to excuse themselves to go to the bathroom after they eat to spit up. And that, unfortunately, is the way they live. But they also have heartburn, where they feel regurgitation. And it's very important to differentiate, or to find out who has achalasia and who actually has reflux disease, because the treatments are very different. If you do a Nissen fundoplication on someone with achalasia, they're not going to do very well, right? I mean, they're already very tight at the bottom, and now you've put a wrap around there, so they're obviously going to have more issues. So you have to be very careful. And the other thing is that sometimes cancers of the esophagus or the gastric fundus can also cause dysphagia, and you also would not want to do a Heller or a POEM on someone with what we call pseudo-achalasia, or achalasia caused by a cancer. So in terms of symptoms, again, dysphagia, sometimes belching, and weight loss, all of these are common things that are seen that people might complain about. In terms of what we do for these patients, endoscopy really is the standard of care initially, where you want to look, make sure that they don't have a cancer, and then you can do a barium study or an esophagogram to make sure that you've identified the area of what we call the lower esophagus. Manometry, or high-resolution manometry, is the way of really checking the pressures of the esophagus, and actually is the standard that we go by to make sure that someone actually has achalasia. pH monitoring is not that common for achalasia patients, but more common that we might use for someone with reflux disease. So what do we see? We basically see food. When we do an endoscopy, you might see food or debris. And on today's case, when Ernesto goes down initially, we'll have to clean out the esophagus, because even if people haven't been eating for 1 or 2 days, many times they'll have a lot of food and fluid in the esophagus just because it doesn't empty very well. And we'll assess all of that to make sure things are cleared out. When we look at this by x-ray, I wish this would, let's see, is this going to work? Maybe not. Okay, this pointer's not working. And is my arrow working? No, okay. Anyways, the picture towards me here is the classic finding of achalasia, where it narrows down to what we call a bird's beak. And this is called type 1 achalasia, where there is an absence of peristalsis. Type 2, the one in the middle, is where we get simultaneous contractions. And this is the most common kind that we want to do surgery or a POEM for. And type 3, the far one, is where the esophagus becomes very dilated, almost like the sigmoid colon, and you get very high pressures in the esophagus, and that's called pressurization, or type 3 achalasia. In terms of manometry, normally we see a progression or a peristalsis of these waves as they move forward through the esophagus. In achalasia, the picture on your right does not show a progression. It's basically just a simultaneous contraction, and that is the signs or the actual diagnosis for achalasia. Well, how can we treat achalasia? Some people can try medical therapy, and medical therapy has been around for decades. And this usually is things that will cause smooth muscle relaxation, such as calcium channel blockers or oral nitrates, things like nifedipine. And people can take these medicines, and they may lower their blood pressure, so it may give some headaches as well. But it only works about 10 to 20% of the time. So it's not a common thing. to do, and you want to give it before meals. All right. So every time before someone eats, they take their medicine, and it may help the relaxation of the lower esophageal sphincter. About 30 years ago, or 25 years ago, the idea of relaxing that lower esophageal sphincter was developed by a gastroenterologist named J. Pashrika, and you're going to hear his name again later on in my talk, but he was the first one to identify the use of Botox. Botulinum toxin is a paralyzing agent. It lasts for about 3 to 4 months. In my country, or maybe here as well, people use it for wrinkles. You inject it into your forehead, and you look good, all right? But it goes away, and then you look like you used to look. Well, the same thing happens in the esophagus. If you use that to relax the lower esophageal sphincter, within 3 to 6 months, it's back to being tight again. So it doesn't work very well. So Botox, though, can be utilized. It's an easy procedure. It is very expensive. At least in my country, the botulinum toxin is probably the most expensive liquid. Even though it's a very small amount, it's more expensive than plutonium. You can buy plutonium easier than Botox. So here's the studies from J. Pashrika that basically shows, I'm going to try to get a pointer while I talk here, that shows that when you do the Botox, it basically causes a relaxation in the lower esophageal sphincter better than actual, placebo, all right? And so it is something that we'll utilize, and it works for the majority of people, but you can only use it maybe twice, all right? So after 3 months or 6 months, you can repeat it, all right? But it's only, as I said, twice that you can do that. All right, and here you can see the studies that work. So what do we know about Botox? It works about 2 out of 3 times, all right, which is not bad. But you have to retreat, all right? It's not a permanent. So achalasia is a permanent disease, and Botox is a temporary solution, so it doesn't work. The other thing that happens with Botox is that it causes scarring at the submucosa. And so for when we would try to do surgery after Botox, it could be very challenging, all right, to do a Heller myotomy in those patients. All right, so let's move on. So what else can we do? Let's maybe this pointer wasn't working, so maybe if we can see. Yeah, is it working? Ah, now you got it. See, I needed you to come up here. All right, thank you. Okay, all right, because I couldn't get that to work either. Now it's working. Let's see. Look at you, huh? Clap. All right, thank you. All right, wonderful. So pneumatic dilation or balloon dilation is a very common endoscopic therapy for achalasia in areas around the world. And basically, you take a balloon, now not a small balloon, this is a very large balloon. This is 30 millimeters. So unlike the balloons that you might use to dilate a stricture, pneumatic dilation starts at 30 millimeters, then 35 millimeters, and then 40 millimeters to work, all right? In terms of how this works, and there are multiple studies that showed effect, that basically you take this high pressure balloon, you blow it up, but you have to repeat it. It needs to be repeated usually once, twice, maybe 3 times to make it work. And it doesn't work well if you're young, all right? So if you're less than 40 years of age, or if you have a very high lower esophageal sphincter pressure, or if you had chest pain prior to the procedure. You may have chest pain afterwards, but if you had chest pain prior, it doesn't work very well. The other thing is that there are complications from this. You can imagine if you're blowing up a big balloon in the esophagus, you may cause a perforation. And the perforation rates are about 3 to 7%. You may get chest pain, fevers, and bleeding, hematoma. And you also may cause reflux. And we're going to get back to this reflux issue because any treatment for achalasia may eventually cause reflux disease. So if we compare it to surgical myotomy, and in my mind, surgical myotomy or Heller myotomy is the gold standard. And we'll look at that in a second. But if you look at Heller myotomy versus pneumatic dilation, basically they have similar effectiveness, but up until 1 year. And then at 1 year, pneumatic dilation falls off, and you have to repeat the procedure. Versus open Heller, it's still also surgery superior, but pneumatic dilation was somewhat suboptimal. In this study here, they didn't use a big enough balloon. So let's talk about Heller. So Heller myotomy is over 100 years old. This is not a new procedure. And you can see it was back in 1913 that Heller described this, going through the abdomen. And then it was described about 40 years later going through the chest, through a thoracotomy by Ellis. And this was a big surgery. You would obviously open up the chest on the left side and then cut the muscles along the esophagus down onto the stomach. And about 25 years ago, Carlos Pellegrini, a surgeon up in Seattle, Washington, a thoracic surgeon, did it with thoracoscopy rather than thoracotomy. And then that's the next step, was to do it basically abdominally or through a Heller myotomy. So this is what a Heller myotomy looks like. Basically, the patients are here, surgeon stands between the legs, and it takes 5 small incisions. And basically what we do is you cut the muscles for about 2 or 3 centimeters on the stomach, across the lower esophageal sphincter, and for about 6 centimeters on the esophagus, trying to avoid the vagus nerve. And this is what it looks like laparoscopically. You can see here that this is the mucosa. There are still a couple circular fibers crossing this. And this procedure takes several hours, and it is something that is commonly done up until the last couple of years, now that POEM has become more popular. So a surgical myotomy, like any surgery, does have procedures, but specific to the myotomy itself, about 10 to 20% of the people will get reflux. Once you open up that lower esophageal sphincter to allow the food to go through, you also can allow the food to come back up again. So people can actually have gastroesophageal reflux disease. Before the myotomy, they probably had esophageal reflux. Food would go down, stop at the lower esophageal sphincter, and then come back up again. So not really acid reflux, but just esophageal reflux. The other thing is that people can have recurrence in their dysphagia. Achalasia cannot be cured. This is an incurable disease. No matter what you do, medical, endoscopic, or surgical therapy, you cannot cure the disease. And unfortunately, the disease affects the esophagus. So you may open up that lower esophageal sphincter, but over time, the esophagus will eventually lose its function and eventually, unfortunately, not work. So one of the things, at least that was identified, and this was at Vanderbilt University by a gentleman named Bill Richards, he took 20 patients and he did a Heller, and then he did a Heller with what's called a door fundoplication to look at the disease of reflux. He was convinced that they would be equal, but unfortunately, or fortunately, I should say, they weren't. So people with this fundoplication only had less than a 10% reflux rate. Those without it had almost a 50% reflux rate after doing a surgical myotomy. Now, the problem is that this data only goes out 6 months. And so I think many people with a Heller myotomy later on will still have reflux. And this is what the door fundoplication looks like. Here is the Heller myotomy here. We take a piece of the stomach and literally sew it over the top of that, like this here. And that is supposed to be the reflux issue. Some people do what's called a toupee fundoplication, which is taking the stomach behind the esophagus and doing a partial wrap. And this is what it looks like. Now, you can imagine this woman is not from Ohio, because this is not what people in Ohio look like. It would be way over here and way over here. But this is a very easy surgery, all right? This is not hard to recover. It's 5 small incisions. It's an overnight stay. And these people do quite well. So why look for something else? Well, it's all because of NOTES, all right? So NOTES was natural orifice transluminal endoscopic surgery. And back in the mid-2000s, it was identified that we could make a hole through the stomach, through the colon, through the vagina, and enter into the abdominal cavity to actually look around the abdominal cavity, take out the appendix, do gallbladder surgery, things like that. Well, doing gallbladder surgery through the stomach or through the vagina really never was any better than laparoscopic cholecystectomy. But what it showed us is that making a hole in the GI tract isn't the catastrophe that we used to think it was. So 30 years ago, if you did a colonoscopy and you made a hole in the colon, you know, everyone's, oh my God, it's terrible, all right? We have to go to surgery. We have to sew that up and everything. But now we realize that making a hole isn't such a big deal, all right? That the body tolerates it very well. And during that time period, there was a gastroenterologist, again, this person, Jay Pashrika, all right, who's a very innovative gastroenterologist doing notes research. So in the 2000s, it was not a good time to be a pig because in the United States, all of our research was in pigs, and we were doing all of this work on these animals. And what he did is he went through the esophagus to try to just do some notes research, and he saw the muscles of the esophagus, and he said, I wonder if I could cut the muscles like a Heller myotomy without having to do surgery. Now, he never did it in humans. This was just an experimental approach. But then along came this surgeon here, Haru Inoue, who is a thoracic surgeon in Yokohama. He's now in Tokyo, who came up with the idea. He practiced in the animal lab, and he was able to perform the first POEM procedure in humans. I met him after his 20th procedure, and I thought he was crazy. Making a hole in the esophagus and going into the chest, this is terrible. I mean, people are going to die from this. And so at first, as Ernesto said, I wasn't really convinced that this was the way to go, and this was about 5 or 6 years ago. But what it turned out was he was very clever. He knew that the body could tolerate this as long as we did a couple different things. All right? Now, let's take one step back first off. Why do we need to replace Heller myotomy? Heller myotomy, which has been around for 100 years, it's simple, it's effective, and it seems to be very safe. All right? Well, the problem is it's still abdominal surgery. You still have to get into the abdomen. It still can cause pain. And this is the other thing, is that when we do the surgery, you have to dissect around the esophagus, and we disrupt what's called that phrenoesophageal ligament, or the attachments around the diaphragm, and that's why you get that 50% reflux rate if you don't add the door fundoplication. So there isn't the inherent disadvantages. The other thing is abdominal surgery in my country, the average BMI of patients that I operate on is 35, okay? Yeah, okay? And that's the average. It goes up every day for most of these people. So therefore, if I can avoid it, the one thing to understand is everyone's esophagus is the same. At a BMI of 18 or 48, the esophagus is the same. And so therefore, for me, it seems an easier way to go. Okay, let's talk about POEM, peroral endoscopic myotomy. What advantages, and again, these advantages are theoretical. We still have to work and prove this, but there is no abdominal entry. There's no surgery involved, all right? So there's no scars. I write less pain, but these people still are uncomfortable, all right? They stay overnight for one night, and they do have some chest discomfort and a little belly discomfort. But we aren't dissecting around the diaphragm, so we preserve this anti-reflux mechanism. What are the disadvantages? Well, in the beginning, it's more difficult to perform. It takes about 20 cases to really become very competent or proficient at POEM, but it's not a lot, okay? You can also cause pneumoperitoneum, and you'll see today during our procedure that we'll be using carbon dioxide, just like for laparoscopy, but it will go through the endoscope, and that can go out into the abdominal cavity, and it can go into the chest and the mediastinum. But the most important thing is it's only been around. Dr. Inoue first did this about 8 years ago. So there is no 10-year data. There is no 20-year data. So we don't know how well this is going to work. The longest data we have right now is about 3 years out, comparing POEM to Heller. And I'll show you some of that in a little bit. So let's kind of take a look. So this is what POEM looks like. So we're in the esophagus. All right. Here's the esophagus. This is a cap, a clear cap here. And we're going to inject some dye into the submucosa. All right. This is a methylene blue. This is just an endoscopic needle or a sclerotherapy needle. And we're going to make a bleb or an area here. Then we're going to take this little knife, looks like a triangle. It's called a triangle tip knife. and we're going to go ahead and make a cut along the mucosa longitudinally for several centimeters. These are all done under general anesthesia. The patients have to be asleep, and they also have to be paralyzed for us to do this. And we'll make this cut, and we'll go on for about 2 centimeters. Then what we'll do is we'll take our cap, and we'll drive it through the opening into this submucosa. And you can see the mucosa is down here. And now you see what I describe as cotton candy. I'm not sure if cotton candy is here, but it's like, okay, good. So, and you can see now that we're in a tunnel. And you can see this is all the submucosa. Here's the muscle. Here's the mucosa. And we're going to keep driving the scope down the esophagus onto the stomach. Now, you can see we're in this tunnel. It's a long tunnel. We'll come back out, and then we'll go back into the natural esophagus. Here's the natural esophagus. And you can see that we've injected blue dye here, and we're going to go, here's blue dye as well. And we're going to go ahead, and when we look backwards, you can see there's blue dye on the stomach here. We need to make sure that when you do the myotomy, that part of the myotomy is on the stomach. So now, here we go. Here are the circular muscle fibers that are horizontal, and we're going to start cutting them. And these are the longitudinal ones that are left behind. Some surgeons or some doctors around the world take both the longitudinal and the circular fibers. I personally just do the circular fibers. There are no studies to show that taking both of them make it any better in terms of the results. But here you can see we're going to keep dividing the circular fibers, and then we'll come back out. And now you can see that's a nice division here. These are all the longitudinal fibers here. The circular fibers are separated. And we'll come back out of our tunnel, and then we'll close the tunnel. All right? Well, these are just endoscopic clips. And we just literally clip close the mucosal opening so that nothing can leak into there. The operation in the beginning takes several hours. It's probably about a 45, and here's what it looks like. So now the barium swallow we get after the procedure here. You can see all the clips in the esophagus. And then when we follow the barium down, it now goes through very easily. And that's the important thing, all right? As I said, we aren't curing any disease. All we're trying to do is make people feel better. So in our series, the reflux rate, the gastroesophageal, let me go back, sorry, is about 10 to 40%. So all of the patients after this procedure go home on proton pump inhibitors for at least 6 months because they are at risk for reflux disease. Pneumoperitoneum, whereby we have to sometimes put a little needle in, or a Varesh needle or an angiocath into the abdomen to decompress the abdomen, is about 10%. All right? And you'll see today, if the patient gets very distended, we may have to put a little needle in to decompress the abdominal cavity. We had one patient with pneumothorax, and out of the 120 patients we've done in the last 5 years, we have 5 patients with persistent dysphagia, which is about 5 to 8%. So the procedure seems to be working pretty well. So the questions, though, for the future are, is it safe? It seems to be. I was very worried in the beginning about infection. We haven't had any infectious issues, and there have been about 6,000 cases worldwide now with POEM. And there have been very little issues with infection. There have been some issues with bleeding. I know of 3 cases in China where they had to go back in, 1 case in Chicago, and several cases in Japan where the patient had bleeding. We had 2 cases of bleeding. One was a patient that was on heparin for the procedure. She had a blood clot, a pulmonary embolus, and that probably is why she bled. The next question is the effectiveness. As I told you, our results, the actual results around the world are also quite good. From Europe and from Japan, at 3-year data, it's about 85 to 95% effective. It's not perfect, all right, but it seems quite effective. There is definitely a potential for reflux. As I said, it probably varies from 10 to maybe 40%. The most important question, I think, are these last two. One is how durable, and that basically is unknown. We don't know what's going to happen to these patients 10 years from now or 20 years from now. But I can tell you, if the poem doesn't work, we can always come back and do a Heller. If the poem doesn't work and we've done it on the anterior wall, which is what you'll see today, we can always come back and do a poem on the posterior wall. Next week, I have my first patient that is 2 years out from a poem, and she has her dysphagia back again. And I'm going to bring her back and do a posterior poem on her because she has residual pressure or non-relaxation at her lower esophageal sphincter. The final thing is patient acceptance. Achalasia is very rare. There is never going to be a prospective randomized trial of thousands of patients like you can have with other diseases comparing one result to the other. So basically what we'll do is we'll keep pushing this forward just like you're doing here today and identify the results. And if the results seem good, we'll keep pushing forward. All right. If they're not good, then we'll take a step back. But as it is right now, 5 years ago, if I had achalasia, I would have had a Heller, personally. 4 years ago, I would have had a Heller. 3 years ago, I would have a poem. 2 years ago, definitely a poem. And now, of course, today, as I stand here, if I get achalasia, I'm going to get a poem. Because it's quick, it's safe, there's no surgery, and again, if it doesn't work, we can always come back and do something else. Because remember, we're not curing cancer. You can't cure this disease. All we're trying to do is make those patients feel better and accept the idea of being able to, let's say, go to a restaurant and eat. Great. Thank you very much. All right. Do you want to come help me with questions? Do you want to help me with the questions in case they need to ask in Spanish or no? Okay. Yeah, sí.
Forgive my mistakes with the language, please. I had two patients, no responders to open surgery,
Yeah.
to myotomy.
Yeah.
Myotomy. One of them is afraid to have a dilation,
Mhm.
a traumatic dilation.
Yeah.
The endoscopist is afraid.
Right.
So I have treated her with Botox with success.
Okay.
And the other one, she has vigorous achalasia.
Okay.
Hypercontractile.
Right. Type 3, sure. Uh-huh.
So I want to know if are they a good candidate?
Sure. So out of our 120 cases, 15 of them are after a Heller. People that had surgery in the past. As recent as 3 years ago, one of my patients from one of my partners had a similar non-response after Heller. And I also have a patient that was 40 years out, okay, amongst those 15 patients. Of those 15, 14 have all done very well, all right? So we can do poem after Heller. So in a patient like this that has a good response to Botox, that means that there is still muscle that can be relaxed, and I would do a posterior poem on that patient and stay away from where they did the Heller. The type 3 or the vigorous achalasia, they also can respond, but we would want to have a manometry to know where they actually are having their most pressures, because unlike a Heller, where you can only go up from the abdomen about 6 centimeters, we can start up here with a poem. We can make the poem, we can make it a 20 centimeter myotomy if they have high pressures here, here, here. And so many times what I'll do for those is I'll study the manometry, find out exactly where their pressures are highest, and make sure that I start high enough to do the poem. And those patients, some don't even need the lower esophageal sphincter cut, if they have mostly pressures here. But if it's truly achalasia, I would start high for that vigorous one and then work all the way down. But the best patient is the type 2, all right? The ones that have the simultaneous contractions. And they do best with surgery, they do best with poem, but we don't always have the luxury of selecting those patients. But yes, I would say that those two might be someone that maybe Ernesto can help you with somewhere down the road. Okay? Thank you. Anything? Yeah, yes, sir. So my youngest is 17, okay? There are cases in China and Japan of younger, 8, 9, 10-year-olds, all right? You know, to understand, though, is that if you are having achalasia at that young of an age, unfortunately, even with a myotomy, you may, at the age of 30, your esophagus may not function, you know, with or without a myotomy. But yes, it can be done in children as well. Yeah. Anything else? Wow. Okay. So the settings for the Irby, okay. So again, your Irby and my Irby. So Irby is just a company, all right, and they have a cautery machine that is commonly used to do this procedure, but also for surgical procedures. Argon plasma coagulation, which is a spray, is commonly, like your Irby in your OR does argon, right? Yeah. So the settings that we use depends on which Irby machine you have. So I can give you my email and I can hook you up with the company to help you guide it based on which generation Irby you have. But I'll definitely be able to help you with that.
Regarding the refluxes after this,
Right.
between difference between Heller myotomy
Yeah.
and usually we have to do a fund application
Right.
because of the refluxes. And what about with this?
Yeah. So again, I'm somewhat biased because I'm very much into the poem group now, but Heller patients also have reflux, and we don't follow patients very long. So unlike a patient with cancer or hypertension, that may be someone that we follow for many years, once we do a Heller myotomy, if the patients feel good, they never come back again. And so they may be having reflux. There was a good study at one of our meetings last May that showed that people with achalasia don't feel reflux well. Their esophagus doesn't sense heartburn like a normal esophagus might, so that they may have reflux after a Heller at a higher rate than what we identify. For the patients that I do POEM on, at 6 months after the procedure, I do a Bravo test, which is a little capsule in the esophagus to measure acid. And I do that off medications. And if they don't have reflux, then I stop the proton pump inhibitors. But it is definitely something, again, that is important. But I think most of the patients that can't swallow would definitely trade spitting up and not swallowing for just taking a Prilosec or a Nexium pill once a day. You know, for them, a quality of life is much improved in that situation. So.
Respecto a la manometría, ¿hace manometría antes y después del procedimiento? Do you do manometry after, before and after the procedure?
Okay. So has anyone in the room ever had a manometry themselves? That you have? Okay. Would you ever want to come back and have it again? Right. Okay. So no one wants to have manometry again. It's, you know, like a nasogastric tube. All right. So what I'll do is what's called a timed barium swallow. So we give them a fixed dosing of barium. It's about 150 cc's, and they take an X-ray at 1 minute, 2 minutes, and 5 minutes, and we measure the column of barium and the width of barium. And we'll do this before the surgery, and we'll do this after the surgery at 3 months. And that is kind of correlates with our manometry. If someone actually needs a manometry, like this patient I was telling you about that was 2 years out that I'm bringing back for another POEM, I'll take them to the GI lab, make them sleepy, and then put the manometry catheter down while I do an endoscopy. So I'll do it together because no one, as I said, will come back and have the tube put down the nose. Yes, sir. Right. So when they see me, they'll have an SF-12, which is a quality of life, as well as a GERD and dysphagia scoring that we'll do when I meet them in the office. They'll do it again at 2 months and at 6 months. And my fellow right now is working on our 2-year and 3-year follow-ups. She's making phone calls now. The problem for achalasia is it's very rare. And so many of my patients come from all around the United States. And if they're feeling well, like I live in Ohio, and if they're in Kentucky, they're not going to come back and see me. But I think it's important for us to follow our data. So yes, we do kind of look at that. And it looks, the quality is improved. You know, I mean, it definitely is improved. But this is not randomized data. This is just prospectively collected data. You know, so there are no trials of POEM versus Heller or POEM versus placebo. You know, so again, it's scientifically, it maybe is not as clean as a randomized prospective trial, but it's all we have. Yes, sir.
Tough question. As a surgeon, as an endoscopic surgeon, which one do you prefer? Ehlers myotomy, lap?
So a couple months ago, I had a lap Heller and a POEM on the same day. The patient also had a diverticulum that I had to resect laparoscopically. I sweated much more with the laparoscopic Heller, and the POEM was enjoyable. So personally, I think over time, the POEM is easier even for someone that has done surgery for this disease. I think it seems to be, although it's stressful, if you guys are watching today, you'll see that while we're working in the esophagus, in the mediastinum, the heart's like this, okay? And so Ernesto will see his heart will be going like this too, because you'll be seeing as we work down in the chest, it is kind of a place that we are not commonly in. But yes, I personally would prefer doing POEMs rather than Heller now. Yes, sir.
You said that about the 50% of patients persist with GERD, but with the increase of body weight after the procedure, how many percent?
It's, you know, again, I haven't looked at actual BMI change versus reflux. That's a good question. Maybe we can look at, you know, that's a good idea. I can have my fellows look into that. Honestly, I have achalasia patients with BMIs of 40, and I don't understand if you have such trouble eating, how you maintain that. But it's basically because they're sucking candy, they're sucking down, you know, milkshakes or ice cream, and they're maintaining their weights. So it's not, but I also have a patient that I just saw in the office that's lost 80 pounds. You know, so some patients will also lose a lot of weight before they seek medical care. Reflux, the only downside of taking a proton pump inhibitor is probably for women, you know, with bone density issues. There's no risk for cancer. There's no risk for other issues in terms of other problems in the GI tract. But there's definitely, so any patients of mine, I make sure that we follow their calciums, their magnesiums, and also bone densities very closely. So, what else? Yes, sir.
What do you think, or which is your experience with making the submucosal tunnel with a dilation balloon?
So that's a very good question. I don't do that. There is a surgeon that I know very well that likes to do that out in Portland, where he'll get into the tunnel and he'll take a balloon and he'll start opening it. I just think I can do it better by hand. For those of you that, how many surgeons in the room do laparoscopic inguinal hernia repair? Is that a common thing to be done? So laparoscopic inguinal hernias? Okay. Okay, fine. So making the tunnel with a balloon is like making the preperitoneal space with a balloon, like a totally extraperitoneal, a TEP procedure. this isn't important. I don't do TEPS. I do what's called a TAP, which is transabdominal, and I make the tunnels. I make this dissection myself. It can be done, but I'm not sure it makes it any quicker, though. So, can I ask one question? How many people have seen patients with achalasia? Okay, so it's pretty common. All right. Again, remember, in the United States, 5,000 cases a year only. An average university, like a place that I work at, saw 20 cases a year only. 20, all right? So it's not very common. And so it's very hard to gain cases. And I was telling Ernesto, before I started doing poem, I only would do 2, maybe 3 or 4 Hellers a year. In 5 years, I've done 120 poems. It's just people come out of the woodwork. People come from all around. So you'll see now that this hospital opens up for doing poem, you may all of a sudden start seeing an influx of people with achalasia or even with Chagas, all right, coming to get medical or surgical care for you. So. Are we all done? Excellent. All right. All right, bueno. All right, gracias. Thank you. Was that good? Was that helpful? Yeah. Okay. All right.
Bueno, vamos a pasar a la cirugía. Va a estar la transmisión del quirófano aquí. El micrófono pues va a estar abierto para quien quiera hacer alguna pregunta. Va a haber tanto la transmisión en vivo como el audio, ¿no? Para lo que se quiera preguntar. Y los que se registraron, el colegio y el CIMA va a dar al final la constancia o después vienen a recogerla. Y listo, y nada más. ¿Alguna pregunta? Muchas gracias por habernos acompañado. Should we go?
Let's do it.
Bueno, pues tómense un descansito de 15 minutos, 20 minutos. Dr. Morris, if you can sign this so they scan your signature to put it in the
Certificate?
certificate.
Sure. Where do you want me to sign?